Okay, Assalamualaikum, Selamat Pagi, Good Morning, Chosan and Vanakkam, and welcome to the CPC. Today it is the Department of Medicine's turn, and we have the lovely Dr. Rathika Rajah, who will lead the discussion and the presentation today, and the unfortunate but highly capable Dr. Shien will be presenting the case. We're also very lucky to have Dr. Leong from Radiology, Dr. Be, who is on the way, I am assured, Dr. Rathika from Pathology, Dr. Rathika from Pathology, I'm looking at the wrong person. And unfortunately, Dato' Ayub will not be joining us, but I'm sure Dr. Be will be able to speak and speak and speak. Oh, Dr. Ayub is here. Assalamualaikum. Okay, so the topic today is when the heart fools the brain. And without further delay, I will hand over to Dr. Rathika to lead the discussion. Over to you.
Good morning, everyone. My name is Rathika. So without further ado, we will start the CPC. But prior to that, prior to us starting our CPC, just a gentle reminder to all medical students, you are required to stay till the end of the CPC. Thank you. So we'll start our CPC now. So, good morning, Dr. Tan. Dr. Tan, this is your scenario. We have a 43-year-old gentleman who's a chronic smoker. He has underlying dyslipidemia on atorvastatin 40 on night. He came to the emergency department with complaints of worsening dizziness, which started 2 hours prior to arrival to emergency. Therefore, stroke call was activated. Now, as the medical registrar attending the stroke call, what further questions would you ask?
Okay, good morning everyone. I'm Dr. Tan here. So first of all, I think, as a patient presented with worsening disease of dizziness, worsening symptoms of dizziness, so I would like to further ask the exact durations of the symptoms, the dizziness, how long the dizziness already exactly occurs.
So the actual onset of the symptoms was 2 days ago. However, it was just mild. So 2 hours prior to arrival to emergency department, it was worsening in trend. So that's what triggered patient to come to the hospital.
Okay. Then I will further ask further questions for the symptoms of strokes, like any blurring of visions, any facial asymmetry.
No blurring of vision, no facial asymmetry.
Slurred speech.
No slurred speech.
Any one-sided body weakness?
No one-sided body weakness.
Okay. So since stroke call activated, so I will also would like to know whether patient have any recent trauma to the head.
No trauma.
Any recent surgery done for the patients?
No surgery.
No surgery. Or is patient's dyslipidemic on statin? But whether patient got any antiplatelet or any old medications, list antiplatelet, anticoagulant?
No, as far as we know, patient claimed that he's not on any antiplatelet or anticoagulant.
Yeah, I think that's all I would like to know. Thank you.
Okay, so just a quick history based on what Dr. Tan asked just now. Patient's dizziness started 2 days ago, and it became worse 2 hours prior to arrival to emergency department. So this patient had no prior history of trauma, no recent surgery, not on any antiplatelet and not on any anticoagulant too. So patient denied having any choking symptoms. There was no tinnitus, there was no blurring of vision or one-sided weakness. Patient also denied having any sudden slurring of speech and also no bleeding tendencies. So, Dr. Tan, the next question will be, what findings would you like to elicit from examining this patient?
For clinical examination, definitely first of all, when we attend stroke call, we will try to we have to know the vital signs of the patients, what's the BP, pulse rate, temperature, dextrostic, so to see any possibility of stroke mimic causes. Then I would like to go for full CNS examinations, especially to assess the NIHSS score. Yeah, what we will do is definitely first of all, I would like to assess the GCS of the patients. Then after the orientation of the patients to time, place, and person. Subsequently, also any gaze palsy, any visual field defect. Then after that, yeah, to see any dysarthria, any facial asymmetry. Then last but not least, yeah, the power motor of the upper limb and lower limb. And then, yeah, so any cerebral sign is important since patient is dizziness. And then cerebral sign, yeah. Yeah, so I would like to know, and other systemic examinations.
Okay, very good. So basically, you're attending a stroke call. You wanted to know the NIHSS. So now, when patient came in, his GCS was full, pupils equal, reactive bilaterally. He can speak in full sentence, no slurring of speech, no facial asymmetry. There's no gaze preference. There's horizontal nystagmus. Vital signs were stable with BP 117/84, pulse rate 103, dextrostic 6.8. The power of bilateral upper and lower limbs were full, 5/5. There's no any other cerebellar signs noted. So NIHSS for this patient was 0 at time of presentation. Therefore, at this juncture, what do you think your clinical diagnosis is before I reveal the imaging to you?
So dizziness, but NIHSS is 0. Yeah, I mean clinically, clinical diagnosis. So I will clinically diagnose the patients likely to have this postural, may possible of this postural circulation stroke, what we call postural circulation infarct. In view of the presenting symptom is dizziness, although the NIHSS is 0 for now. Yeah.
Okay, all right. So since it's a stroke activation, we will have our CT stroke protocol. I'm giving you a CT brain plane, CTA, and also a CT perfusion plane first. Dr. Tan, do you want to use the mouse to scroll it again?
Yeah, I will scroll it again.
Okay. So now the computer is yours.
Okay. 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 So there's an obvious Okay, this is a plain CT brain. So there's an obvious right parietal area. There's obvious CT lesions at the right parietal region, and I think previously. Wait, Okay. Yeah, we can appreciate quite a hypodensity also at the left cerebellar region. Hypodensity at the left cerebellar, and there's also hyperdensity at the right parietal region. Oh, yeah, a bit suspicious lesion at the right temporal, also hypodensity lesions also from the right temporal region. So in conclusion, yeah, we can appreciate from this plain CT brain, there's a left cerebellar hypodensity lesion together with a right temporal hypodensity lesion, as well as a hypodensity lesion at the parietal region.
Okay. The next, I'm going to give CTA. Again, you can scroll if you want.
Yeah, I think I scrolled it. Sorry. Here. Okay, for me, this CTA has not shown any obvious stenosis. So in conclusion, I would say this: there's no large vessel occlusion.
Next will be the CT perfusion.
Okay, CT. Okay, CT. Yeah. Stop. Okay, from the CTP, okay, we can see from the time to peak, there is a abnormality, delayed time to peak at the left cerebellar region. In concurs with this, there is also delay in the cerebral blood flow, and cerebral blood volume (CBV) and reduced cerebral blood flow here also at the left cerebellar region. And the parietal, right? Oh, that's also that's so obvious. Delayed time to peak at the right temporal in concurs with the delayed in the cerebral blood flow, and blood flow as well as the blood volume reduced. So it's in concordance with our findings.
Okay, thank you, Dr. Tan. So what is your working diagnosis at this moment?
Working diagnosis. Okay. So patient is few infarcts, including left cerebellar, ischemic infarct with right temporal, complicated with this right parietal bleed. So it's a multiple infarct multiple ischemic infarcts complicated with hemorrhage and likely due to cardioemboli causes. So we have to rule any cardioemboli that lead to the multiple infarct.
Okay, very good. So our working diagnosis at this moment of time was multifocal infarcts, which is at the left cerebellum, right temporal with right parietal hemorrhage, likely cardioembolic in origin. So Dr. Tan, when we say cardioembolic emboli in origin, what do you think it could be the cause?
Oh, okay. So possible causes of cardioemboli. So we have to rule out any possibility of vegetation from the heart valve, or possible any LV clot in the heart, as well as last but not least, any tumor in the heart that can lead to the systemic emboli that cause strokes.
Okay, so now you're the registrar attending the stroke call. You got this patient, this the CT scan, this the scenario. Now your acute management for reperfusion therapy, yes or no? What do you think?
Okay. So for this patient came in with but the dizziness symptom already started since 2 days ago. So patient already out of thrombolytic windows. I mean, the window period more beyond 4.5 hours. Then patients also got hemorrhage in the right parietal region. So it's also not, it's contraindicated for thrombolysis. Another thing is, patient also currently have a new, the NIHSS score is 0. There's no obvious any neurological deficit. So at this point of time, I think reperfusion therapy is not suitable for the patient. So I will not do that.
Okay, very good. So what further, now you're done with your stroke call, you can take a deep breath. So what further history would you like to ask this patient, should this patient was admitted to your ward?
Okay, so further history, then we have to rule out the causes of cardioemboli. So from there, definitely first we want to know any cardiac symptom like shortness of breath, any chest pain, and patient got any heart failure symptoms, and any syncopal attack before that. Then I also would like to know whether any history of fever, especially prolonged fever, night sweat, as well as any history of any recent catheter insertions or any patient also any TB. And after that, I also would like to know whether got any high-risk behavior in the patients, whether patient is involved in this IVDU or that. And then also I would like to know further any family history of malignancy or any heart event before that from the patients, and constitutional symptom as well, any significant loss of appetite, loss of weight. That's it. I think I would like to know.
Okay, so the further history that we got for the patient, not as complete as your questions, but so dizziness started 2 days prior, worsening in trend, which triggered the patient to seek treatment. So the dizziness was associated with vomiting, there's headache, but he has been unwell for the past 8 months. He has been having on and off chest tightness. He has reduced effort tolerance, autopnia, and PND. He visited Klinik Kesihatan and he was given a referral letter to cardiology for further workup. But unfortunately, patient defaulted. There was no TB contact, no night sweats, no fever. There's constitutional symptoms, loss of appetite, loss of weight, 8 kilos in 2 months. No family history of malignancy, no cardiac issues. And to answer your questions, he denied having any high-risk behavior. He has no recent hospital admission or any catheter insertion on him prior to this. So moving on to his baseline investigations, you have your full blood count, renal function, liver function test, coagulation profile, fasting lipid profile, and viral screening. What do you think about these results?
Yeah, from the blood investigation, I can see the obvious thing is the raised total cholesterol, especially the LDL, and otherwise, other blood investigation was quite normal for me, generally quite normal. Yeah.
All right, thank you. So this is the chest X-ray on admission. What do you think?
Chest X-ray. Okay, this is chest X-ray. Okay, the trachea is central. This is not a rotated film. And cardiomegaly. Otherwise, I can't appreciate any obvious consolidations or on any obvious consolidation or any mass seen in the chest X-ray.
Okay, very good, thank you. So the next challenging part, ECG. Please interpret the ECG.
Yeah, ECG. Okay, ECG. This ECG is sinus rhythm with regular RR interval. There is a quite poor R wave progression and significant T inversions from V1 to V4. Just can't appreciate whether the P wave is two boxes. Also like component of power. P pulmonale is there. Yeah, I think that's it.
Okay. So we will leave it to cardiology later to scrutinize on your ECG. As a physician and neurofellow, yes, I think that's sufficient for me for the moment. So in the ward, the neurology team saw him and we decided to proceed with MRI brain. Now this MRI brain was ordered to assess the etiology of stroke, etiology of the infarct and bleed, and to guide us on further management. So can I have Dr. Leong from our consultant interventional radiologist from radiology department to discuss on the imaging?
Thank you, Dr. Rathika. Morning, I'm Leong from radiology department. So we have several sets of investigations. So go through the scan that Dr. Rathika has shown just now, and I'll show you the salient findings for this case. So we have a non-contrast CT brain, CT angiogram of the head and neck region, as well as the CT perfusion that Dr. Rathika showed just now, which was done on the 7th of June. And almost a week later, about 5 days, we had the MRI brain. And we have some serial chest radiographs as well. So this is a non-contrast CT brain that you've seen earlier. And so my lecturer always told me, if you are not sure, just look at the arrow sign. Okay. So the arrow points to you the area that we have been shown earlier, the hypodensity around the left cerebellar area. So if you compare right and left, for the brain, it's good because we can always compare right and left. Look for asymmetry. So when we compare to the right side, you can see that this is more hypodense, and it involves both the gray and white matter. Okay, and it involves more than one slice. That means it's not artifactual, because when it happens in the posterior fossa, because of the confine of the bones here, we tend to have a lot of artifacts such as this. Okay, so when things are contiguous, they involve the gray and white matter, so it's more convincing to be a true lesion. So there's an infarct, or at least a lesion here. Okay, at this point of time, we can call it infarct. We can also call it an edema. There may be something hiding there. Okay, a lesion hiding there, causing edema around this region. Okay. And this very subtle finding over the right temporal region as well. So this slide showing you the hyperdensity in the right parietal region, in the axial, coronal, as well as the sagittal view. So this area is not a typical area that we see for the hypertensive bleeds. So when we say common areas of hypertensive bleeds, and it usually involves the basal ganglia, okay, the pons, posterior fossa, but not at this region. And we also know that from the history, the BP is also not high. And this hyperdensity, if you compare to the bone, it is way less hyperdense. Okay, so bones is the densest thing that we can see on the CT brain, and this is less, and it is like like cotton wool kind of thing. The density is, if you give a number, is about 60-ish to 80 as a number, and the bones will go up to hundreds and thousands, okay? And this bleed is very peripherally located, and you can see that there's actually not much of edema surrounding it. So this bleed, combining with the hypodensity that we have, is, I would say, a not common combination, that you get hypodense area, which looks like a stroke, and also you get bleeds like this. So then we further scrutinize other images to look for clues. So Dr. Rathika has shown you the video of the CT angiogram, which it was acquired in the axial slice, so moving up in the axial plane. So these are the images that we call the VRT, virtual reconstruction, where we reconstruct it to show you the 3D image, so easier to interpret. So again, look at the arrows. This is the right carotid artery. So this is the common area to have disease. If this case will be, for example, artery-to-artery emboli stroke due to arteriosclerosis. So usually it will involve the proximal ICA carotid bifurcation. So from this image, you can see that it's very clean, very nice. And the right vertebral artery, because our concern is in the posterior fossa, is also very normal. This is the aortic arch. It appears very normal. Left carotid artery, as well as the left vertebral arteries. So we do not see any significant extracranial carotid or vertebral artery disease. And this is the CTA, reconstruction of the brain. So as you can see here, this is the basilar artery, right vertebral artery, left vertebral arteries. Right ICA, left ICA, MCAs, as well as the ACAs. So our concern here is that we are having left cerebellar stroke as well as the right temporal stroke. So CTA is very good to look at large vessel occlusion, up to medial vessel occlusion. So if we look at the areas of the infarct, they are actually relatively small. Okay, so CTA is actually not sensitive to pick up all these distal vessel occlusions. So CTA, the limitation is to look up to at most a distal medial vessel occlusion. Okay, so the reason why we are scrutinizing this image, because if there is a large vessel occlusion or even up to medial vessel occlusions, there's a role of doing intervention in this case, where we can try to discuss and if there's a role to remove the clots. Yeah. So this is a CT perfusion. Okay. Where's my arrow? Oh yeah, here. Okay, so this is a CT perfusion showing the standard area that we will scrutinize, which is at the level of the basal ganglia. Because if there's any large vessel occlusion, for example, the MCA or the basilar, the PCA or the ACA, definitely on this slice you will pick up some abnormalities. So from here we can see that it is quite symmetry. So at one glance, you are quite relaxed that, okay, nothing big is happening here. Okay, then we move on. And CT perfusion should never be interpreted by itself. It has to be interpreted together with the plain CT scan. So correlating with the plain CT scan, we can tell that there's actually an area of perfusion mismatch at the left cerebellar area. So as mentioned earlier, there's increase in this map is called the time to peak. This is called the delay time. And this map is called the cerebral blood volume. This map is called cerebral blood flow. This map is called mean transit time. And this is the source image, CTP source image. So combining this image, we can infer that there's already an established infarct over the left cerebellar region. And over the right temporal region, we do not see any obvious mismatch seen. So moving on, we have this MRI done about 4 to 5 days later. So MRI comparing to CT scan, it takes longer to acquire, but it has a very good soft tissue differentiation. That's why you can see so much clearly compared to the CT scan. Okay, so this is T2 sequence where it is sensitive to pick up fluids. Okay, so any pathology in our body, there'll be increase in fluid, edema, inflammation. So that's the basis of MRI that we do. So T2, you see very bright, very wedge-shaped, territorial-like area which is involved. So it tells you that this is like a vascular part, vascular territory, rather than a lesion sitting there causing edema. Okay? Because imagine that there's a vessel here sitting here. Vessel will always come from here, come here, and these vessels get blocked. That's why you get this wedge-shaped kind of abnormality. So flare will further show you, will further enhance the abnormality, because flare, in this sequence, it will suppress the normal fluid. So if you see the CSF, it's being suppressed, okay? But the edema fluid stays. And this is the sequence DWI and ADC, the main sequence that we use to diagnose is there any infarction. So please be aware that the MRI was already done like several days after the onset, almost a week. So DWI in a in the classic stroke, acute stroke, DWI will be bright in this map, and this is called ADC map, apparent diffusion coefficient. It will become low, which is very dark. But in this case, you can see that the DWI is very high, but the ADC is slightly hypo-intense. Okay? It is not as we expected in stroke. So this is likely because it's happened for almost a week already. So this is already in the subacute phase. Right? So combination of these images tells us that this is a left cerebellar subacute infarct. Then we move on to the right temporal lobe. Similar findings of high T2, flare, high DWI, and intermediate to hypointense ADC. So there's a concurrent right temporal subacute infarction. So these two findings we notice on the CT scan, but we clearly see it better on MRI. But there are also findings that cannot be seen on the CT scan, which is this. So there's another concurrent acute lacunar infarction at the right centrum semi-ovale. So this cannot be resolved by the resolution of CT scan. And actually, there's another finding in this MRI, if anyone can pick up. So there's really another infarct here. Okay, so this is T2. Okay, this is DWI. Okay, this is ADC. If you agree with me, there's another lesion here. Okay, so other than the two territorial infarcts that we see another two infarcts in another two areas. So this multi-territorial infarcts. So it really supports the idea of an embolic stroke. Okay, so this is another thing that CT scan will not be able to pick up. If you remember the hyperdensity at the right parietal region, it corresponds to this area, which is bleed. So this sequence is called susceptibility weighted imaging, or we call SWI. It is very sensitive to pick up things like bleeds or calcification in the brain. So in this context, we are looking for hemorrhage. And this is the only area which shows hyperdensity on the CT scan. But if you can see, there are much more. All these small, tiny areas that shows hypo-intense signal, or we describe as blooming artifacts, this represents areas of hemorrhages. And these are all not seen on the CT scan. So now we have multi-territorial, multifocal infarcts, and multifocal, multi-territorial hemorrhages. On top of that, we also give contrast, and in this case, and you can see that very subtle, very small focus, but there's actually a solid enhancing component in the area of the right temporal infarct. And another focus at the region where we saw the parietal hemorrhage earlier, there's also another enhancing focus. So it points to us that something else is sitting at this region. Okay? When something enhancing and it looks solid, that means there's another lesion is sitting within that area. So another very small lesion at the left occipital lobe. So this is a chest radiograph on presentation. Again, let's look at the arrow. So this is there's increase in the cardiothoracic ratio, borderline, okay? And heart is borderline and enlarged. However, another salient findings here is you can see the carina. Usually the angle is less than 90 degrees, meaning the kaki is more narrow. So this is very splayed away. And always look at the left heart border, and we can see that it's straightened already. If you put the ruler there, the ruler sits nicely there, that means something is wrong. Okay? Usually the left cardiac border should be concave. And on top of that, also when we look at the radiograph, it is not very sensitive, but actually we can see that the left cardiophrenic angle is blunted. There's some pleural effusion going on, And this is actually confirmed from the CTA that we saw earlier. There's actually bilateral pleural effusion. Yeah. So all in all, CT scan shows us that there are two areas of territorial infarct. One focus on parenchymal hemorrhage, but no large and medium vessel occlusion, which is the target that we look for to treat for any ischemic stroke. As the MRI and the MRI shows us even more, they are not just the temporal and left cerebellar subacute infarctions. There are also another two focus of lacunar infarctions and multi-areal parenchymal hemorrhages. And on top of that, we also have solid components, which strongly suggest a component of metastasis, a tumor. So the impression is a multifocal acute subacute infarcts, likely embolic in origin, with multiple intraparenchymal hemorrhages. So together with the foci of a solid enhancement, this strongly suggests metastatic foci. All right. As for the radiograph, as I mentioned earlier, carina splaying and straightening of the left heart border always points to a left atrial enlargement. Okay, pass it back to Dr. Rathika.
Thank you, Dr. Leong. So next question for Dr. Tan. Okay, so Dr. Tan, after looking at the images, CT scan, MRI, X-rays, so what other investigation would you like to order for this patient? Probably name one.
Oh, yeah, we haven't looked for our echocardiography.
Okay, very good. So I'm not a cardiologist, so we just put the prop on the patient's chest. So what do you think, a quick explanation about this picture?
Okay.
What do you see? No, it's just a picture, Dr. Shawar. So the moving one, Dr. Bay will be explaining later.
Okay, this is a TTE. On the left-hand side, this is a parasternal, long axis parasternal view. And yeah, I think we can see a very obvious hyperechoic mass at the left atrium. Yeah, it's a very huge hyperechoic mass at the left atrium, I think extending into the left ventricle as well. Also with a stop, right? Yeah, with a stop and with a hyperechoic mass from the left atrium extending to the left ventricle.
Okay. Can you
Okay. So so we can see this is the huge hyperechoic mass here. I'm thinking this is a stop from extending. The mass is extending from the left atrium itself, and it's too big until it extends into your left ventricle already. So this is I think this is a left ventricle. This is a left atrium, and LVOT is here, and this is our aortic.
All right, to see if you're right, can we call upon Dr. Bae Boon Chong, our cardiology fellow, to teach us on the echo?
Thank you, Dr. Tan, for the explanations. I'm going to continue with the imaging part of the echo that done. So I'll concentrate more on the left atrial mass. So we did the transthoracic echo for this patient. So as what Dr. Tan is trying to mention, so there's a mass actually attached to the left atrium. If you don't understand where is the anatomy, actually I put the normal reference on the top. So if you get the normal echo, you're supposed to be like this. By the way, this is my echo, so it's supposed to be normal. So so this is a normal echo for the heart. So you compare, so there's a mass inside the left atrium. So the mass is actually attached to the base of the aortic root, somewhere near here. So it is from this view, it's near to the aortic root there. So it's the mass is actually prolapsing through the mitral valve, going out and going to the left ventricles. So if you look from the short axis view from here, it's actually protruding through the whole valve. It's actually obstructing the whole mitral valve. So it's mimic your obstruction of the mitral valve, which is like the mitral stenosis. So like what Dr. Leong mentioned to you, the X-ray have a straightening of the left heart border, which is for undergrad that going for exam. Usually if you saw this kind of X-ray, you're going to suspect mitral stenosis. So when you have a straightening of a left heart border, that is a sign that you want to look for when you want to look for the ECG and also the echo to look hard for the sign of the MS. So this patient doesn't have true MS, it's because of the functional. The mass is obstructing the mitral valve. So if you look at the M mode, actually, if you look at the whole opening of the mitral valve, it's actually occupying the whole mitral valve the area. So it's actually blocking the opening of the mitral valve. So it's only have limited space for the blood to flow. So you have these pseudo obstructions. There's always a transient blood stasis inside the left atrium that prone for clot formations. So if you look from this view, it's actually going in and out through the mitral valve that obstructing the flow. And then when there's not much of a space for the mitral valve to close, they're also causing the mitral regurgitation as well at the backflow here. So we proceed with the transesophageal echocardiography. The purpose is to look for where is the attachment of the stalk of the mass, because we want to find where is the area so that our surgeon can go in and to decide where to resect the whole area. So it's actually attached to the interatrial septum. This is a left atrium, this is a right atrium. So this is the interatrial septum. If you remember the anatomy when you're in first year medical school, this is the area that is a fossa ovalis, that the place that supposed to be closed. So for this patient, there is a mass attached to it at this area. So you can see that the mass is actually protruding through the mitral valve, and it's very near to the aortic root area. Okay, I put at the different angles. So this is a same view, but scanning at the same time. So you can see that the mass is actually not fully rounded, smooth surface. It's actually a lot of small friable tissue that can fly off. That's why you can see that from the CT and also the MRI, there's multiple territory. One of it, probably part of the pieces of the tissue from the mass already emboli, or the clot that may have formed on the surface of the mass that have emboli, or can cause, or the mass can cause the obstruction, causing the stasis of the blood in the left atrium, causing the blood clot and emboli. Okay, this is another view that you can see that from the sideway, how the movement of the mass through the mitral valve. And you can see the small pieces of mass that attach to it. This is easily get emboli. So if you can 3D view of this, this view is actually looking from surgeon views. When surgeon go in for surgery, this is the view that they saw. It's actually attached to the interatrial septum here, and the mass is going through the mitral valve and going in. So you look at the sideway, it's actually blocking the whole mitral valve. So the size is actually quite big, 5.2 times 3 centimeter. This is the largest myxoma that I've ever seen. Okay. So based on the echo, it's a large polypoid, but papillary because a small part of the tissue is attached to it, and at the interatrial surface of the left atrium, which collapsing into the left ventricle through the mitral valve, causing functional MS. There's no obvious clot in the LAA. The function is still acceptable, and the features of this is suggestive of a left atrial myxoma. So when you have a mass in the cardiac, there's things to look for, because this is you have to think of differential diagnosis. What we have is features that suggestive of myxoma. It can be still other types of tumor or other type of mass. It's rarely to be a clot itself because it's too big to be attached to one side and it's not moving. And if you do MRI, these are the features that you can help to differentiate whether it is a myxoma or the thrombus. But it all depends on how long the thrombus that stay in the heart. I think we have currently one case in the ward that is dilemma whether it's myxoma or the thrombus. The mass, the size is even bigger than this case. So it's still in the work waiting for surgery. So what are the features to look for, whether it's benign or malignant? Okay, so when it's on the right side, you have to think of whether is it malignancy infiltrations, if there's involvement with the hepatocellular carcinoma, and you have effusion, then you have to think of whether this is already malignant effusions. And usually, when it's on the not on the usual side that you used to think of, you have to think of whether this is malignant in origin. So the best way to differentiate is still the surgery and remove it. So there's an example to differentiate based on echo. If you think that this is a myxoma, so you have to fulfill all these criteria. But for the case that you saw, it's not actually rounded as what we thought. So this is not easy to differentiate based on just the echo. So the best is still the removal. And the patient have, as what Dr. Tan trying to tell you is the ECG that changes. So the changes have the T-wave inversion in anterior leads, which suggestive there may be a occlusion in the left anterior descending artery, which is proven in the angiogram. We can see that there's a stenosis in the LAD. So this is a LAD, this is a CERC. So the CERC and the RCA are not that bad. The problem is in the LAD. That may explain why the ECG changes. And the other thing is the ECG changes also suggestive of the problem with the pseudo MS that caused all the changes that what he's trying to tell you. So myxoma is one of the common, most common primary cardiac tumor in adults. So mean age about 50 years old with female predominance around 70%. So the clinical presentation of cardiac myxoma can be highly variable depending on the size of the tumor and how fast the tumor grows. And heart failure is commonly present. So as you can see from this case, the patient have heart failure symptom prior to this. And there's a risk of embolization is about 29%. And as what you can think of is when you have cardiac myxoma, you have to think of whether is it a syndromic or not syndromic. For non-syndromic cardiac myxoma, mostly located at the left atrium and tend to form the mass in the intracavity mass attached by a stalk. But for the case that you saw, the stalk is not very obvious. It's just the whole mass attached to it. So what other things that can be think of is a Carney complex, which is comprised up to 5% of the myxoma patient. Usually happen in the young patients, autosomal dominant disorder. They have these features of Carney facies. You can see the changes in the skin. And in the echo, you can see actually multiple myxoma, not only in one cavity. It can be happen in multiple sites on the heart. And it also can have extra cardiac mass as well, either in the pituitary or in the adrenal. All the endocrine glands have the possibility of developing this myxoma. So there's a lot of diagnostic criteria that can use to diagnose this Carney complex. And there's different types of myxoma. The case that the patient have is polypoid plus little bit of papillary types. Usually the polypoid is very large size that you commonly can hear the tumor plot during your auscultations. And it's associated with constitutional symptoms like what this patient have. And always have, when you have combination with the papillary types, usually have embolic events. So these are the other example of a myxoma. It can have a very huge myxoma in the right atrium. And also can be calcified depending how long already the myxoma in the body. And it can have infections, especially when they have IE. So usually we don't need to take biopsies. Based on the imaging, you can roughly diagnose the myxoma. But the best is still surgical removal and send for HPE. So these are the example of different types of tumors. I think that's all.
Thank you, Dr. Bay. So, in interest of time, we'll go slightly faster. So, the provisional diagnosis for this patient is multifocal infarcts with right parietal hemorrhage, likely cardioembolic in origin, which is because of our left atrial myxoma. So, Dr. Tan, how would you manage this case?
Okay, in terms of management, so pharmacotherapy, medical therapy, I think there is a role to start oral anticoagulation for these patients. Subsequently, risk factor optimization is very important. Control the BP, keep BP less than 140/90, DXT 7.8 to 10. Then LDL, as this patient was dyslipidemic, the LDL a bit high. So high risk patient, we should keep less than 1.8 or ensure compliance to the statin. And I think the next utmost is most important surgical management, surgical removal of the mass.
Okay, very good. So for this patient, we had multidisciplinary team involvement, neuro, cardio, cardiothoracic, and also radiology team. We started this patient on anticoagulant, which was subcutaneous, and strictly monitored the patient's clinical condition post-initiation of our anticoagulation. And we referred to cardiothoracic for surgical removal of left atrial mass. So without further ado, I would like to call Dr. Nurul Atika, our medical officer from the histopathology unit, to briefly explain about the HPE findings of this mass.
Hello, Bismillahirrahmanirrahim. Assalamualaikum and a very good morning to distinguished professors, my lecturers, my fellow colleagues and also medical students. So Atika here from Histopath. I'm going to share on the histopathological examination of the mass seen in this case. Okay, so we received a specimen that was labeled as left atrial myxoma, and they are an irregular mass, and they measure 68 times 60 times 25 mm. So this is the mass we receive. So externally, it appears whitish brown with areas with myxoid looking. You can see it's quite shiny, and they are a little vague papillary pattern. You can see like some small projections on the surface. It's not smooth. Okay, so on the right side of the picture, you can see that the cut section shows hemorrhagic and gelatinous cut surface. And microscopically, you can see myxoma cells with abundant myxoid background. So how do you know it's myxoid? Because you can see somewhat blue tinge in the background. Okay, that's how we know it's a myxoid. Okay, so the myxoma cells morphology, they are arranged in clusters, cords, and singly distribution, as shown in the arrows over here. Okay, this in the middle is the cords and clusters, and some in singly distribution. And in other areas, we see some hemorrhagic areas and also scattered hemosiderin-laden macrophages, which correspond with our gross examination. We see some brownish hemorrhagic areas, right? Okay, this is the cytomorphology of the tumor cells. The myxoma cells actually shows us ovoid and plumb spindle-shaped, and they show us hyperchromatic nuclei with inconspicuous nucleoli. That means it's not very prominent, and with abundant eosinophilic cytoplasm, as you can see over here. Okay, and sometimes these myxoma cells can be arranged around the blood vessels, okay, as you can see over here. And this is what we call as perivascular rings of myxoma cells. And we proceed with immunohistochemistry of calretinine, and we see that the myxoma cells are diffusely positive for calretinine, which further confirms that this is a myxoma cells. Okay, so to conclude, this is a cardiac myxoma, consistent, and this is the essential and desirable diagnostic criteria adapted from WHO classification of tumors. So the essential criteria to diagnose myxoma is the presence of myxoma cells within a myxoid stroma, which we have in this case, with appropriate location. So this, which is also correspond to this to our patient. It is in left atrium, which is found in about 75% of cases, and also desirable calretinine reactivity within myxoma cells, and also the perivascular rings. Okay, so so I think that's all about it. Thank you so much.
Thank you, Dr. Atika. So next, can we have our cardiothoracic surgeon, Ms. Dato Ayub, to say a bit on cardiac myxoma?
Hello, good morning everyone, and Assalamualaikum. Do we have a medical student here? Final year medical student? You need to make sure 100% pass for this year. Is it okay? Okay. When the heart fools the brains. Remember, when the heart fools the brain, make sure there's no love fool the brains, okay, or fool the hearts. You need to study hard before your exam and pass the exam. Forget about the love. Okay? So when we talked about the cardiac myxoma, is common primary neoplasm of the heart. It's benign but functionally malignant. Of course, the bay on and also from the neurologist is for potential embolizations and then can cause obstructions. And most common is left atrium, and occurrence may be sporadic in majority, but it can be familiar and it's a part of a Carney complex. And predominant in female 3-in-1s, and mainstay treatment, of course, the mainstay of treatment is surgical excisions. Surgical resections is the only effective therapeutic options for patients with cardiac myxoma, especially we need to take up the stop. Surgery should not be delayed, try it as soon as possible because of suction and embolizations. Of course, and then we need to do a surgery, we need to do special. Surgery is a simple surgery, you just need to do a cardioplegia. Cardioplegia is like a hemiplegia, we paralyze the heart. Cardioplegia, we full of potassium. That means we stop the heart. Okay? So the risk of tumor fractation, embolization, and all the palpitation need to be avoided only after we give the cardioplegia. That means we stop the heart before the operations. And then there's a multiple approach to remove the myxoma. There's left atrial, transeptal, and to make sure try not to damage the myxoma. Of course, this is tumor. It's quite bored when I show the pictures, I show you the videos. Of course, the surgery is simple for us. Why is the video not getting? Oh. Huh?
Because the screen saver's playing.
Oh. Oh,
It's a video.
oh, it's a video, yeah.
Cannot. What? Where's the video? Video here.
Yeah, you'll see.
Cannot open.
Why cannot open? Semalam okay je.
Oh. You press play.
Oh, you have to press this one, double click this one.
I know there's a different video.
Where is the video?
This is NC. Let me try the second video.
Oh, you right click and see for any option. Right click. Open with.
Any video any video. Okay. First video first.
Yeah,
first video.
Oh, first video first. You do the first, change the first video. Here's the second one. I think you right click, go to the far right. Okay. Open with. First video. Open with. Media.
Okay, media. Okay. The one who first we cannulate the aorta. This is aorta after we do the median sternotomy. So this is cannulation of aorta. Put a pump. This is arterial cannulations. Make sure you secure both cannulations. And then the operation is we do a bicaval operation. We cannulate superior vena cava and inferior vena cava. We need to do it gently to make sure the tumor is not being embolized. This is IVC. Okay, then we open the left atrium. This is the cardioplegia to stop the heart. Okay, cross clamp the heart. Cross clamp, need stop the heart. Give the plegia, and then you see the heart stop already. The heart become asystole. Then we can open the left atrium. See, the heart asystole. The heart is dead. Okay, we open the left atrium. With the pump sucker. Pump sucker is one of the component of the bypass machine. We suck the blood and recirculate back the blood to the machine. This is left atrial approach. This is how we prepare the heart. So second video. Okay, this is big tumor, bicaval also, cross clamp, make it faster. Oh. Cannot be. This is a tumor. Remove gently. Make sure you remove the stop. If we don't remove the stop, it will be recurrence. If the stop is adhere or attached, we need to reconstruct the wall. Letak, saya takut saya kembali. Okay. So we that we remove the tumor. So make sure it is clean. Make sure there's no remnants. Make sure the structure that we remove or the stop we remove, there's no holes. If there is hole, we need to repair or reconstruct the wall using PT epigraph or any tissue bovine pericardium. Okay, there I will end my presentations. Any question? All right.
Thank you, Mr. Ayub. So in summary, this is a young male with underlying dyslipidemia presented with dizziness. A serial CT and MRI brain showed presence of multifocal infarcts and intraparenchymal bleeds. TTE and TOE was suggestive of left atrial myxoma. He was subjected for surgical excision and HPE confirmed the diagnosis of myxoma. So there's one more missing clue here in this case. Can I have Dr. Leong up quickly once more time to show us what the missing clue is?
Yeah, actually it was not missed retrospectively. So this is actually throughout this case, all the images, MRI, CT brain. I think this is my favorite slide. Yeah, so the simplest imaging investigation, but gives you a lot of information. So this is the X-ray on presentation. Again, the straightening of the left heart border and splaying of the carina and some effusions. And so you see after the myxoma was removed, and the myxoma is also causing some pseudo-MS appearance. So you can see that the left heart border has returned to the normal concavity, and the heart size has gone back to the normal cardiothoracic ratio, and the splaying of the carina has also resolved. Okay, yeah. So thanks to the surgeon, remove the huge tumor, we get back a normal heart now. Yeah.
So thank you, Dr. Leong. So just a few more last slides. So whenever you have a stroke call, be it young or old, yes, we always think of traditional risk factors, diabetes, hypertension, dyslipidemia, but please do not forget, this is a young patient. Besides the traditional risk factors, patients have many other causes of young strokes, which we should not forget. Just like this patient, the cardiac myxoma is one that we should not miss that caused stroke in him. So now, in this case, what's the catch? This is a cardioembolic stroke with infarcts and bleeds in a left atrial myxoma. This patient is a case of a high risk for further thrombus formation and atrial arrhythmias. So do we anticoagulate this kind of patient? And if we were to anticoagulate, when do we start anticoagulation? So to anticoagulate, yes or no, as we have heard what Dr. Bay mentioned, for cardiac myxomas, the answer is surgical removal. But if you were to look at papers and our case, this patient has very high risk to cause embolism because the tumor surface itself is irregular. The tumor itself has irregular surface. It's huge and the location itself is at an atypical location. So no doubt, though the definitive treatment is surgical excision, and so far there are no recommendations for preoperative anticoagulation or thrombotic therapy for left atrial myxoma. But because of high risk, we still anticoagulated this patient. We started him on subcut Clexane 60 mg twice daily. Now, after initiation, we did monitor him closely. We monitored his GCS, we monitored his neurological symptoms, and we also repeated imaging prior to sending him for the operation. So since we are starting anticoagulation, is there a proper guideline on when to actually start anticoagulation in this kind of case pre-op? Now, we do not have a guideline to show us that when to start in cases of cardiac myxoma, in cases of bleeds. So what we did was, to guide us, we used ELAN trial. ELAN trial is a large trial which is used to guide us on starting anticoagulation in post-ischemic stroke patients with atrial fibrillation. Now, they have divided the stroke locations to minor, major, and minor, moderate, and major. So for our patients, the location of the strokes, majority of it were at the major locations and also the posterior side. Therefore, if you were to look at this flow chart, this patient has major stroke, and the time of initiation of anticoagulation is 6 + 1 day. Now, because this is for ischemic stroke, do not forget our patient has a background of intraparenchymal hemorrhage. We started at day 7. We monitored his condition again closely. So the take-home message from this case is, all that glitters is not gold. So examine, look hard for every possibility when searching for the cause of stroke, especially in cases of young stroke. So if you want to initiate anticoagulant in a cardioembolic stroke complicated by hemorrhage, it's not an absolute contraindication. So all that we need to do is have a multidisciplinary discussion and strict monitoring of patients' condition. So that's all from me and Dr. Tan and the neuro team. So thank you and happy holidays.